Good afternoon, ladies and gentlemen. My name is Bernard de Bruin from Aalst in Belgium, and it's my pleasure to chair this fifth module of a series of webinars devoted to coronary physiology or invasive coronary physiology and how to do that, how to apply that. Now, the program of this whole season, I would say, of coronary physiology was divided in 6 episodes of module. The first were devoted to the basics, then we went to more specific lesion and patients subsets, also clinical situations like the last module devoted to post-PCI fractional flow reserve. But today we are going to focus on something that we can call a second generation index, or a real novel dimension in coronary physiology, namely the PPG index, which stands for Pullback Pressure Gradient. Now, as you all know, of course, the coronary circulation, I'm trying to advance the slides, there it comes. The coronary circulation, the microcirculation. We are not going to speak of the microcirculation today. We are really going to focus on the left part of the slides. And to evaluate the epicardial vessels, well, we need fractional flow reserve. But, and this is the topic of today, we also need more refined indices, and this is the PPG. I'm not able to advance the slide, so okay, there it is. Thank you. So again, we are going to focus on the epicardial vessel, and we are going to try to understand how it comes that stationary FFR, the classical FFR, is insufficient to understand the full picture of the epicardial problem. We will try to understand what is the information that we can extract from pre-PCI physiology, because we have to understand from the start on that PPG is, of course, to be obtained before PCI, but predicts a lot of what is going to happen immediately after and probably long-term after PCI, and to what extent this information is actionable. So to do this, I'm surrounded by 3 excellent colleagues and friends, excellent speakers. Divaka Pereira, who will touch upon the basis of diffuse versus multiple focal disease. Then we have asked to Jeroen Sonk from Aalst to explain what is the basics actually of the principle of PPG, pullback pressure gradient. And then finally, Carlos Collet, also from the center here in Aalst, will disclose actually the first clinical outcome data related to these measurements of PPG. So without further ado, I hand it over to Divaka. The floor is yours, Divaka.
Thank you, Bernard, and thanks to everyone for tuning in. So why have we got a webinar on serial and diffuse disease? It's because it is really a very common finding. If you consider all of the patients who undergo PCI who then have physiology, probably a quarter to 1/3 will have one of these patterns of disease rather than just your isolated focal coronary lesion. And you'll see serial lesions on the leftmost screen, a combination of serial and diffuse disease on the next panel, and so on. If you just focus on the patient represented in the 3rd panel, I'll take you through some of the ways in which we assess this artery. So I hope you can all see that still image, which shows a dominant right coronary artery with what look to be 2 focal lesions on angiography. So the first question is this disease significant? And I'm sure most of you who've tuned in are already converts, and you would go on to do a distal measurement with the pressure transducer in the distal vessel to measure FFR. And I can tell you that the FFR was 0.60. So we know it's significant. The patients got to the lab because they've got symptoms, and we are going to treat that disease. But which lesion is causing that FFR to be 0.60? Is it the proximal, the distal, or both? Now, we can try and guess at that, but a better way to do this would be to do an FFR pullback. So with continuous hyperemia, a manual, slow, and steady pullback can be carried out. And this is the sort of image you get. The red trace, as you can see, is aortic pressure. The green is distal coronary pressure, and the yellow line above it is the ratio, which is FFR. And I've written in the values there for ease. So we have some visual qualitative assessment of which lesions are causing a problem. And you might say that there's a more focal proximal lesion and a slightly more diffuse segment, but really two lesions in series. Okay, well, we know the vessel's significant, we know the probable contribution, but what will the effect be of treating any one lesion on the other? You know, what's the residual FFR going to be? We have three options. We can guess, pick one lesion angiographically, treat it and remeasure, and that's quite often done and reasonable. We can try and use the visual appraisal of the pullback using those sorts of numbers I've given you, or we can try and quantitatively characterize the pullback and try and predict the result. And that's really the focus of this webinar. Now, this is what we did. This was the first part of the procedure. You'll see that the more proximal lesion has been treated with balloon dilatation. We then repeated the physiology. And what you'll notice is that now that distal lesion appears to be responsible for a much greater drop in pressure than we thought that distal lesion did beforehand. So that's changed quite significantly. And we'll come back to that pressure trace a little bit later, but let's talk for a moment about quantitative characterization of pullback and prediction of results. You'll hear a lot more about the PPG index from Jeroen and Carlos later, but suffice to say that it is possible to identify at least three patterns of disease. On the left is a focal lesion. This is visually characterized. On the left is a focal lesion. You'll see the angiogram. The middle panel is a focal lesion, followed by another segment of disease, which is diffuse. And then the third panel to your right is a diffuse segment of disease. Now, we can quantify this, but really, this is very subjective. And a huge advance has been made in coming up with a quantitative index which can characterize these. And this is called the PPG index, made up of two metrics, which we'll hear about. But essentially, a low value, which you can see on the right panel, is characteristic of diffuse disease, and a high value, closer to 1, very suggestive of focal disease. Now, you've got those numbers, but actually there's also a really beautiful visual illustration that you get when you do a PPG pullback. And if you look now at these three patients, here's a patient with fairly diffuse disease, and you get a visual impression of that quantitative index, if that makes sense. Whereas here there are two focal lesions which are shown, not just that visual assessment, but the number 2. So the PPG index can be used to give you a number, but it can also be used to both detect and measure the impact of serial lesions. But as I said, not to steal the thunder of my later speakers and colleagues, you'll hear more about that later. So let's go back to our patient. On the left panel was the physiology we had at the start of the procedure, before we did any treatment. And we predicted that there'd be a drop of about 0.16 FFR units. And yet, after we treat that proximal lesion, there's a drop of 0.40. So why did our visual assessment and qualitative assessment of that pullback go so wrong? So let's dive a little bit deeper into the physiology of what causes this pressure drop. Really, the pressure drop is the measurement we make that is a surrogate of flow in the coronary artery. And as flow increases in a quadratic manner, then a pressure drop is caused. And the greater the flow velocity or flow in the artery, the greater the pressure drop. Now, of course, we see this all the time in our cath labs when we do physiology. When you induce hyperemia compared to rest, what happens is that there's a significant increase in coronary flow. That's exactly what hyperemia is meant to do. And you notice that the pressure gradient across the lesion, the pressure drop across the lesion, increases significantly from rest to hyperemia. So the greater the flow, the greater the pressure drop. And of course, this is a property of each lesion. So each lesion will have a particular relationship between flow and pressure drop. And you'll see the progressively less severe lesions shown from red through yellow to green. And in fact, FFR is that measurement, that ratio of pressures that's made at hyperemia, whereas the non-hyperemic pressure ratios deal with a much lower range of pressure drops seen at rest. Now, this pressure drop, this drop in velocity that happens across a lesion is also the reason why it's difficult to assess the significance of a lesion when it occurs in combination with another one, in order to predict what that lesion alone will look like physiologically after you treat it. So the distal lesion would reduce flow velocity or flow across the proximal lesion, and vice versa. The proximal reduces flow across the distal lesion, and therefore the pressure drop across each is very different alone than it is in combination. And that really is the source of the problem. Now, we looked into this a little bit further, first with a wet lab model where we 3D printed some coronary lesions which were taken from CT coronary angiogram and then plugged that into our model. And we were able to show, using this, that there were significant errors that would be caused by looking at the FFR on a pullback tracing compared to the true FFR if you removed one lesion. And it didn't seem to matter whether you removed the proximal or the distal lesion. And that difference between true and apparent FFR was proportional to the total FFR in the vessel and also the pressure drop across the lesion. Using these, we then came up with a solution which we trialed in 50 patients. And what you'll see is really quite striking, that FFR, when used with a qualitative pullback, will lead to an erroneous assessment in up to a third of patients. And if you use it in a binary sense, about 17% of patients are misclassified. And once you correct for those interacting factors, you're able to reduce the misclassification rate significantly. And it's also worth noting that the non-hyperemic indices are also prone to error. Of course, the magnitude of error seems smaller because, as I said earlier, non-hyperemic pressure ratios operate in a much lower range and at much lower resting pressure gradients. So this is a problem across all indices that we commonly use in the cath labs. I'm going to look at a couple of cases very briefly to illustrate this point. So here's a dominant right coronary artery with seemingly focal lesion in mid-course, and then relatively diffuse segments of disease in both vessels. In fact, this is a case from our cath labs just earlier this week. So the first thing we did was to do a pressure wire assessment with a sensor positioned distally, and what you'll see here is the end of that hyperemic run, showing us a really very significant FFR, 0.49. And this was the corresponding non-hyperemic index, which also showed the total burden of disease to be significant. And this is what a pullback across that vessel looks like. This was from the posterior LV branch back into the proximal vessel. As you pull back, there's a relative plateau showing that there's no relatively normal segment of disease, slow gradient, and then a steep step up. And there's the corresponding non-hyperemic index. And this is what happened after we treated the distal lesion. Now you see that the residual FFR is much greater than you would expect by just looking at the pressure drop that lesion caused in the presence of the more proximal lesion. And this was borne out on non-hyperemic measurements as well. We then went on to treat the more proximal lesion, and you've abolished that gradient and you've achieved an FFR of 0.87 and a non-significant, in a binary sense, non-hyperemic pressure ratio as well. Now here's another right coronary artery, a different patient, a focal lesion before the crux and a more diffuse segment of disease proximally by eye. First measure the FFR, 0.79. Now here's something interesting. When we did non-hyperemic ratios, and the top is an IFR and the bottom is an RFR, this lesion, this vessel was shown to be non-significant. No disease detected at all. And this is what the pullback looked like. Again, you see that there is this focal step up of suggestive of a focal lesion, and then a more diffuse slope showing that more proximal segment to be diffuse. Once again, the non-hyperemic pressure pullback didn't detect any of that disease at all. It didn't even show it to be significant. We then went on and treated that focal lesion. That's what the operator in my institution thought, or I should say, before we treated the focal lesion, we tried to apply our prediction equation and calculated that if you treat that focal lesion distally and take that out of the equation, we should be left with an FFR of 0.87. And actually, that is exactly, in this case, numerically identical result to what we did achieve by treating that lesion. And that's the corresponding non-hyperemic ratios shown there. So just to conclude, this is my own approach to dealing with diffuse disease and serious stenosis. Clearly, start by measuring FFR distally and then do a pullback. And the key to pullback is slow and steady. It only needs to be done manually. It doesn't need a motorized pullback. Then analyze the pullback, obviously visually, but also quantitatively using the PPG index, which we're going to hear a little bit more about in a minute. Then try and predict your physiological outcome. And once you do, reappraise your initial decision. You may proceed with PCI, but it may be more appropriate for the patient to have bypass surgery or medical therapy. And then if you do PCI, you really need to repeat this whole process again. Thank you.
Thank you very much, Divaka. We have now, I would say, 4 or 5 minutes for discussion, and I would like to give the priority to the questions coming from the chat box. At least there is one question which is interesting and which is very practical, and it's to you, Divaka. And it refers probably to the right coronary artery, this big right coronary artery with a tandem lesion. Why did you treat the proximal lesion before the distal one? Is there a reason to do that, or was it just for the sake of the demonstration?
In this case, this patient was enrolled in a study, and we'd asked the operator which lesion they'd treat first on angiography, then we'd show them the pullback and say which one you would treat. So really, that was probably driven by the study protocol. But otherwise, I would try and predict which lesion is most significant and decide whether I'm going to treat both or just one.
Thank you. Carlos, Jeroen, do you have specific questions for Divaka, or?
Yes, Divaka, I was particularly impressed by the pictures that you show with angiographic serial lesions. But then when you do the pullback, you find that there can be a different type of disease. You can have this classical 2 steps pattern in the pullback. You can have 1 step followed by diffuse disease, or you can even have fully diffuse disease. So I was impressed by that, and I think particularly in serial lesions, is it something that you always do a pullback in these cases?
Yes, absolutely, always do a pullback. And from what you've said, Carlos, it shouldn't only be restricted to situations where your eye identifies serial disease. We have to be aware that there could be physiological diffuse or serial lesions. So until you do it, you don't know. So it's got to be something we do every time.
So you actually insisted on the fact that actually many patients have diffuse disease. It depends, of course, how we investigate this diffuse disease. if you just look at the angiogram and you try to figure out whether there are two lesions or whether it is diffuse disease, you cited the number of 30%. My best guess is that if we put an IVUS probe or an OCT catheter in all the patients, virtually all the patients, it will be 85% diffuse disease. Do you agree with that?
I do, definitely. If you do anatomical imaging or a CTCA, I think you'll find a lot more diffuse disease.
Yeah, and I think it is important for several reasons. One of them is conceptually. Very often we used to say, well, these coronary arteries are quoted unquote not significantly diseased, and this is considered interchangeable with normal coronary arteries. Well, we know now that we focus a little bit more on coronary microvascular disorders that many of these minimally diseased vessels do produce a significant gradient with sometimes in 10, 20% of the cases, and fractional floor reserve, which is frankly pathologic. And these are also the cases where it's extremely useful to have a pullback, to try to understand what is going on in these patients and not to focus on the microvasculature, why a piece of the problem is definitely located in the epicardial circulation.
Yes, I agree.
Okay. So I think we will definitely come back to your topic during the discussions of the other presentations, but it's now time to move to the second speaker, and it's my pleasure to introduce again Jeroen Song. Jeroen, okay, the floor is yours.
Well, we're going to speak about the theory and the practicalities, and I think it's very clear, summarizing this discussion. We should measure and determine lesion significance, followed by a pullback, and a pullback can be assessed visually, but also quantitatively nowadays. And this is important because we have to distinguish two endotypes or two patient types even. These are two patients with the same single distal FFR measurement, but as you can clearly see at left, you have a focal, anatomically focal disease with a high translesional gradient, while on the other side you have a diffuse disease, both anatomically and during the pullback. And these patients are going to react differently to our more or less focal therapy that PCI remains to be. So let's go a little bit deeper into this. This is a case example of a patient with focal coronary artery disease. So I think there's no discussion on the invasive angiography. There's a focal lesion in the mid to distal right. And this is confirmed using our FFR wire with the distal FFR value of 0.71. What we did, as we nowadays do in every patient, we perform the pullback, and then you see in the coroventis below in yellow the pullback curve going at your left from distal and at your right your proximal right coronary artery. And then you see a high translesional gradient with a PPG that has been calculated of 0.90. This is a very high value pointing at a functional focal coronary artery disease, and we'll come back to this. So I think it's clear that this patient with this high translesional gradient, positive FFR, is a perfect patient for PCI. So we proceeded as such. This is the balloon, and this is the final result. And then we measure again. And the FFR post-PCI rose up to 0.96. And you can clearly see that the FFR pullback curve post-PCI is almost a flat line. So we restored the epicardial conductance, and we have a high post-PCI FFR, which is a surrogate of clinical endpoints. So this is a patient with focal disease. What is happening in a patient with diffuse coronary artery disease? I think it's clear looking again at the angio that this is what you mentioned, a patient where when you perform an IVUS, you will see diffuse atherosclerosis. It was a patient who had a CT. And there's even a more or less focal angiographic lesion in the mid to distal LAD. Again, we measure FFR, and you see the pullback curve at your right side. And then it's becoming a little bit more difficult because this is more or less diffuse. There are some small steps. So if I ask you as an operator, what is this? Is the diffuse pattern, is it focal and diffuse? is very difficult to interpret. The FFR is 0.71, so I think we should treat this patient. The PPG in this patient was 0.37. This is a low value, pointing at the fact that this is a functional diffuse coronary artery disease. So if you go for PCI in this patient and you implant a long stent because you want to cover all these small steps, you end up with a long stent, but a suboptimal result. Angiographically, I think we can be happy, but looking at the curve and the final post-PCI FFR, we just go up to 0.69. And if you look at the curve, there's no residual focal gradient to tackle anymore. So the restorance of the flow, the conductance, is not well achieved in this case. So, two different types or endotypes of coronary artery disease. On the left side, focal disease, your right side, diffuse disease. Only one patient, in my opinion, is a good target for PCI. The question is, how can we identify this diffuse coronary artery disease? Well, if you ask an expert panel of interventionalists to look at an angiography and to assess focality, and you give them, let's say, 100 cases, in 62% of the cases, they will tell you that this is focal disease. When you compare this with the FFR pullback, and you then want to reassess the pattern of coronary artery disease, you see that physiology is really telling us something else. We reclassify more than 1/3 of the cases. There's a couple of patients with diffuse disease that have focal functional disease, but on the other hand, you see that a lot of focal disease becomes diffuse or a combined focal plus diffuse. And this is very important to know if you want to select your patient. The next step, of course, all these curves, and looking at all these curves, some of them are very easy to interpret. And I think that everybody agrees, Divaka, Bernard, everybody, when you look at this curve on the left upper part of the panel, that this is a diffuse pattern. On the other hand, the right below panel, there you have a very focal disease, so a high PPG. There is no discussion. The discussion starts when we start having traces like this or pullback curves like this. There's a diffuse with a small step. Is this focal? Is this diffuse? Is this the good target? Again, the focal translesional gradient is a bit higher in the proximal to mid part, but there's a diffuse segment following more distally. And the discussion remains in almost all those cases. So it's very difficult to distinguish here between the puppy and the muffin. So the visual interpretation of the pressure pullback curve has a high variability. And then comes in the PPG. Why the PPG? Well, there's a quantitative approach to quantify objectively, reproducibly, the pattern of coronary artery disease. And you have two aspects that we focus on within the equation. The first one is the focality, and this is measured by the maximum pressure gradient during the pullback. And the second component that is within the equation is the length of functional significant disease. And both then were equally weighted and come inside the PPG value. And the PPG value is, let's say, scaled from 0 to 1. And this is a diagnostic tool that will identify, when it's low, the diffuse pattern, when it is high at your right side, the focal pattern. And that is very important to understand. Again, there's a spectrum of coronary artery disease beyond lesion significance. So when you have a positive FFR, it is important to perform a pullback and to objectively quantify the disease pattern. At your left side, a positive FFR with a very low PPG. This is a definitely diffuse coronary artery disease. There's no discussion at the right side. A positive FFR, high PPG, definitely focal, but for sure, in between these two values, you have, or these two cases, you have a lot of cases where discussion could start and where the PPG will help you to identify the predominant diffuse or predominant focal pattern of coronary artery disease. Now going to more practical, how to perform a PPG, you need three things. First of all, you need the pressure wire by Abbott, and then you need the Coroventis console where the PPG is built in, and then an hyperemic agent of your choice. We use intracoronary papaverine, But of course, this is at your preference. And then what do we do? The classical setup, of course, we start with equalizing the wire, we put it distally, and then we prepare for the pullback. And this is a video showing exactly what we do. So you take out your introducer needle, you inject the hyperemic agent, and then when you have stable hyperemia, you press the pullback button in the FFR mode, and then you start a very slow and steady pullback in between 20 and 30 seconds. At your right side, you see the PDPA, so the red and the green, and below the yellow is the FFR pullback curve. And in this case, a case with very diffuse coronary artery disease on the angiography, we have a very focal gradient. At the end, when you reach the catheter tip, you push the stop button, and then you can annotate everything you want. You push the PPG button, and the PPG appears. And in this case, the PPG reached the value of, and here you see the clicking, so the drift correction first, and then the PPG, and the value appears online. And I have to wait for the result. I'm very sorry, I will make you curious. The PPG was 0.75. So once again, this goes towards 1. It's a scale metric from 0 to 1, a high PPG, a very focal gradient, and a good candidate for PCI. So this was, in the first phase, we validated the PPG using motorized FFR pullbacks. We can tell you that we have done the same with manual pullbacks. So you perform a slow and steady pullback in between 20 and 30 seconds. And if you repeat this twice and you ask your colleague to come by and to repeat this pullback, the PPG will look exactly the same. So there is a very easy to perform and very stable result to calculate the PPG. So why is it important? And this is introducing our colleague Carlos. Well, I think in the first case, this patient, a young diabetic patient, has a positive FFR with a very diffuse pattern, so very low PPG. I think we will expect low benefit from PCI, and potentially this patient is better off with optimal medical therapy. While on the other hand, at your right side, you have again a positive FFR with a very focal gradient. This is the patient where PCI is appropriate. So I think Carlos and Bernard, this was my part on the practicality, so it's easy to perform, and I leave the floor back to you.
Thank you very much, Jeroen. You focused on the practicalities of the principle. You didn't dwell too much into the equation, but I think it is right not to do so, because when you go into these maths, it always gives the impression that this is complicated. I think you have, if you want to have more details, you have to go back to the paper Princeps published by Carlos and Jeroen in JCC 2 or 3 years ago. But we have to trust the value. This is let's say fully validated, and we don't have to spend too much attention to the details of the equations. This is unnecessarily complicated. Now, I would like to come back to a practical detail. You have discussed motorized pullback and manual pullback. Can you reassure us and tell us or confirm us that if you want to do PPG tomorrow in your lab, you don't need to have a motorized pullback? Is that correct?
We can confirm this. It is the resulting PPG value is exactly the same. So the paper will soon be published where we compared both motorized with manual, and then the intra and intra-observer variability, and it's always the same value that appears.
Okay, so the pullback, the manual pullback, how long should it be?
Well, what we do, we inject a hyperemic agent, we wait for stable hyperemia, and when you see that you achieve this stable hyperemia, most of the time you have at least a minute to perform a pullback. The pullback itself doesn't have to last much longer than 20 seconds. So it is a slow and steady pace that you have to keep up with. And well, 20-second pullback is perfect to calculate the PPG.
Yeah. And you have shown, I think you even showed the slide, that if you do the pullback and then afterwards I do the pullback, actually the PPG value will be the same, whatever the exact time that it took to both of us to do the pullback. Is that correct also? Because this is important.
Yes, indeed. We have analyzed this also. So the time of the pullback is not influencing the value. Of course, this does not mean that you will compare a 5-second pullback and a 1-minute pullback. But when a 22-second or 28 or 32-second pullback will generate exactly the same value. So we advise to perform a pullback between 20 and 30 seconds. That is the...
Okay. Good. Actually, you have nicely explained that the PPG is a kind of quantitative characterization of a pullback under maximal hyperemia, as we are used to do since ages, actually. The novelty is simply quoted unquoted, the quantification, and that's the whole value of the PPG. If you don't mind, I'm looking at the chat box. There are no questions which are really very relevant to your talk, and I would propose to give Carlos 10 minutes.
Maybe there's one question and for Carlos. Divaka was already speaking about serial lesions. The PPG in serial lesions, Carlos, is this able to detect this focality in serial lesions?
Yeah, that's a very good question. So what we have observed, and we published that paper together with Divaka, is that in the presence of serial lesions, the PPG value will be, let's say, lower than any focal lesion alone. That's the first message. The second message is that there are different types of serial lesions, and we have described 3 patterns. One pattern that is the classical one with 2 drops, 1 drop plus diffuse disease, and fully diffuse. And what the PPG does in these 3 scenarios is that when you have a pullback with the classical 2 steps in the pullback curve, the PPG is going to be higher compared to a fully diffuse pattern of coronary artery disease. Why is this important? Because I think that we have to agree, and I look at Bernard and Divaka, that diffuse coronary artery disease is not a good target for PCI. And this is probably something that we are still not there with the mindset. We're just measuring distal FFR and it's positive and we want to do a PCI. But in my view, the appropriateness of PCI relies not only on the fact that the lesion is hemodynamically significant, but also that the pattern of disease is appropriate for PCI. And I look at you, Divaka, are we ready as an interventional cardiologist to start saying we cannot treat diffuse disease?
I agree with you entirely, Carlos, because if you work backwards where you've done a PCI and you showed a nice case where that had happened, and you find that your physiological result is poor at the end, then you've already implanted a stent and exposed the patient to an intervention. If we can predict that scenario beforehand, it may be that we wouldn't do PCI at all.
Thank you, Divaka. I think the word predict is extremely important in this setting, and this is probably an index which is the best able to predict what will be the result and probably also what will be the outcome of an intervention. So it is pre-PCI physiology that should determine what will happen afterwards, and that's also something new. Carlos, why not to proceed and to go to your presentation on the clinical outcome?
Sure. Thank you, Bernard, for the introduction. And it's really a pleasure for me to show you the data that we have gathered so far on the patient reported and clinical outcomes data on the PPG. So let's start by recapitulating a bit the whole topic of today, which is the differentiation of hemodynamic significant lesions into 2 different types of disease. We have focal disease and we have diffuse disease. And again, you have seen that this is extremely important when you think about how to approach these lesions from the therapy perspective. If we do PCI in focal disease, and I just implanted a stent in that vessel with focal disease, and we do a pullback and with measure of FFR afterwards, you will see that these vessels have high post-PCI FFR. But look what happened when we treat with PCI vessels with diffuse disease. You have probably a good angiographic result at the level of the stent, but when you repeat physiology and you look at your pullback, you will see that there is no gain in FFR, there is no gain in flow, and Jerome has shown a couple of these examples that show this very clearly. So we have been working with the PPG since 3-4 years. We developed the PPG in 2018. We did the first study, which was a proof of concept study. We did that with motorized pullback to standardize the relationship with length. We included in that study 100 patients. And this is the publication that you were referring to, Bernard, that is in JHC a couple of years ago. Then what we did is we extended the validation of the PPG to a multi-center fashion. We kept, for that validation, the motorized pullback. We included 130 patients. And I have to say that in this study, we did CT and OCT before we implanted the stent to understand as well from the atherosclerotic perspective, what is the difference between focal and diffuse disease. And this is a paper that you will see soon in press. Then we extended the clinical validation and we added now 230 patients, this time with manual pullbacks. And in addition to all the information that we have from the functional perspective, we added questionnaires of angina before the PCI and after the PCI to understand what was the rate, one, of recurrent angina after PCI stratified by the PPG, and if the PPG was able to identify those that would benefit the most from PCI. And now, as I'll show you that in the next few slides, we're running a big study. This is PPG Global. This is a 1,000-patient study with manual pullbacks, and now we're going to look at clinical outcomes. We have the hypothesis that patients with diffuse disease are the one doing worse after PCI. We will prove that in a couple of years. When we look at the data that we have gathered so far, this is the distribution of the PPG. You will see that in the data that we have collected, that is coming from 10 centers worldwide, we have PPG's values ranging from 30 to 94, and there is no difference if this is acquired by a motorized pullback or a manual pullback. We have indeed compared these two, and you see very clearly how the PPG derived from a motorized pullback is the same, or has a very high level of correlation with the one derived from manual pullbacks. But and it's probably the most important slide of this part of the presentation is this one. In this plot, you see in the x-axis the PPG. On the right side of the plot, you see high PPG, that means focal disease. On the left side of the horizontal axis, you see low PPGs, that means diffuse disease. In the y-axis of this plot, you have the delta in FFR. So how much was gained by the PCI in that particular vessel. And you see immediately that patients with focal disease have higher changes in FFR compared to patients with diffuse disease or a low PPG that have lower changes and sometimes no changes in FFR after the PCI. If you want to look at this from a more statistical perspective, what we have detected is that the area under the curve of the PPG to predict the change in FFR is extremely high, 0.83. And if you look at the coefficient of determination, in this case 0.46, you can say that the change in conductance is determined by 46% by the pattern of CAD, and this is extremely important information. If you want to look at this only looking at post-PCI FFR without acknowledging or adjusting for baseline disease severity, you have the plot that you see on the screen. Again, in the x-axis, the PPG, and in the y-axis, this time, absolute post-PCI FFR. You see again, a moderate and good relationship between the PPG and post-PCI FFR. And when you look at the area under the curve, is again, a very nice result in terms of prediction of what would be your result based on the PPG that, of course, is pre-PCI. So you have the chance to plan your procedure. Now let's move forward to the next part of the presentation, which is more related to the patient. Here we're seeing again now in numbers how there is a significant difference in post-PCI FFR and functional gain between the PPG tertiles, meaning that patients with high PPG do better. They get better conductance after PCI, they have higher flow after PCI, and it's not a surprise that we will find some positive consequence for the patient in terms of reported outcomes. And this, I want to spend some time explaining you this slide, which is a relationship between the PPG and angina post-PCI. Before I show you the data on post-PCI angina, I would like to show you the baseline Seattle Angina Questionnaires score. The Seattle Angina Questionnaire scores, as you may know, has 3 domains. The first domain is angina frequency. The second domain refers to physical limitation, and the third domain is quality of life. And you see there the 3 bars stratified by colors. The green is focal, the blue is combined or a mix of diffuse and focal disease, and the red is diffuse. When I see this plot, I understand that there is no way that I can know if the patient that is in front of me in the consultation complaining about angina has focal or diffuse disease. This is impossible to know with the information the patient is giving to you. But let me show you what is something that we were surprised or happily surprised when we observed this. When you measure the Seattle Angina Questionnaire again, but this time after the PCI, in this particular case, 6 months after PCI, you see that the patients with focal disease that were treated with PCI have the higher scores in the Seattle Angina Questionnaires in the 3 domains. In the angina frequency domain, meaning that patients with high PPG had less residual angina, in the physical limitation domain, and in the quality of life domain. So we are really helping a lot patients with focal disease. When we look at the magnitude of change, this is the same data, but plotted now. The circle is the baseline where you started, the arrow is where you finish, and the length of this arrow is actually the benefit that the patient had. You see immediately that when you do PCI in patients with diffuse disease, these are the red arrows, there is almost no benefit in terms of angina relief. There is no benefit in terms of less physical limitation. So this is very interesting data. In contrast, when you look at the green arrow, that is patients with focal disease, you see immediately that the length of these arrows are bigger, meaning that the change in the Seattle Angina Questionnaire were higher compared to those with diffuse disease. So the question that now we have, Bernard and Divaka and Jerome, is that we're doing systematically pullbacks now. So every case, independent of the disease severity, we do a pullback. And the first question, of course, is focal disease. There is no question. There is a very good candidate for PCI. But now we have these patients that I show you a case that was shared by me by Niels Johnson. This is a lady that in 2017 came to his cath lab, and she had anatomical diffuse disease. At that time, he measured FFR. It was 0.66. You see the LAD over there. And he did a pullback, and he saved the raw data. So we were able to use the raw data, put in the new Coroventis machine, and calculate the PPG. The PPG 5 years ago was 0.34. And the question that I make to all of you as clinicians is, what would you do with this patient? And I don't know if we can have Divaka, Bernard, and Jerome back on the screen, but the question is, how do you approach these patients? Divaka, I let you see your opinion first.
Okay, so this looks diffusely diseased on any way of looking at it: angiographic, visual, and a low PPG. So I don't think PCI would be a good solution here. And for CABG, there isn't that distal plateau suggestive of a normal vessel that a graft would take either. I would treat this patient with medical help.
What about you, Jerome? Would you do a PCI in this case, full metal jacket, or a Lima to the LAD?
Well, I think you're tempted to try to solve this percutaneously, but the PPG predicts a very low post-PCI FFR. You will not restore flow. So I think I would start with medical therapy, and if the patient remains having a lot of symptoms, and then I would proceed to Lima. But that has to be proven what is the best solution here. Huh?
So, Bernard, I put it more difficult to you. So the patient has an FFR of 66. That is pretty low. That appears to be prognostically relevant. And that is the diffuse disease with low PPG. Do you have a different opinion from Divaka and Jeroen?
Well, I will tell you frankly what we used to do, let's say before the venue of PPG and before we started reasoning in pullback pressure tracings. We would have measured the fractional floor reserve. We would have seen that it was 0.66. It's an impressively low value if the patient has symptoms. What we always do, and I think it's a vast majority of the colleagues all over the places, we will try to find some place in the vessel where we think we can help by putting a stent. And probably we'll say, well, it's diffuse angiographically. We will start with a long stent, and that's how it goes. And very often even, it is even without having a fractional floor reserve to start with. Now, doing the pullback is something that we do since the almost day one of fractional floor reserve. We do that all the time, but nevertheless, I have to admit that it is relatively rare that we refrained from PCI based on the pullback. And now we have PPG, which is a quantitative characterization, and that's the whole difference. It's between eyeballing and quantitation of an index. That's the whole difference. And that's how we did very often. Now that we have learned the lesson, I think that CABG is, in this lady at least, far out a better solution. And also the PPG helps in defining whether placing a Lima here or there might help the patient thoroughly.
Okay. Let me tell you what Niels did, Bernard, because it's extremely interesting. Can I have my slides back, please? So this is, again, 2017, and he had the opportunity to have the patient back in the cath lab this year, in August. And these are the images. So I was actually impressed by how stable is coronary artery disease, at least in this particular case. Niels decided at that time to treat the patient medically, and the patient came back and he measured again a fractional flow reserve, and he did a pullback again. And surprisingly or not surprisingly, the FFR was exactly the same. So the medical therapy was able to stop the progression of the disease, and the PPG seems now a little bit probably more diffuse than before. So I think from this case, I learned a lot. And I have to say that when I look at this pullback curve, I don't see actually any target to place a stent in this type of lesion. So I fully agree with the opinion of you three. So if you allow me to further go on, this is just for the colleagues to know that we are investigating what to do with these patients. And we have created a registry. This is called the PPG Global Registry. We're going to include about 1,000 patients in 25 clinical sites worldwide, US, Europe, Japan, and Australia. All the patients will have an FFR pullback and an online calculation of the PPG. All patients will have post-PCI FFR measured. We're going to, of course, confirm the ability of the PPG to predict post-PCI FFR. But most importantly, we're going to look at how do we, as an interventional cardiologist, react to this fact that we cannot really address diffuse disease. So how many patients are we going to defer from PCI based on the PPG? And of course, one of the most important questions that we have is what are the clinical outcomes of these patients with focal or diffuse disease when treated by PCI? And we'll probably have the results of this study in the next 2 years. So as a conclusion, we have the PPG that is a novel metric based on FFR pullbacks that characterizes the pattern of CAD in a scale from 0 to 1. We know that patients with focal disease are the ones that we can help with PCI. There is nothing we can do as an interventional cardiologist with diffuse coronary artery disease, and we're studying this to see what is the best treatment strategy for these cases. What I think, in my view, the PPG allows is, of course, to recognize the presence of diffuse disease. And when you start doing pullback systematically, you start learning that this is more prevalent than what you thought. it permits the standardization of the diagnosis of the disease. And Bernard, you mentioned a point that I want to go back to, that it reduces the uncertainty in the decision. You have a metric that is reproducible, that can go with your line of thought or against, but helps you reducing the uncertainty in the decision to defer the patient, and that is really welcome in the cath lab. We call this second-generation physiology, and I think this will refine the appropriateness criteria for PCI, particularly in patients with stable coronary artery disease. And of course, we're looking and already designing the randomized clinical trial that would prove the benefit of a PPG guided strategy. Thank you very much for your attention.
Thank you very much, Carlos. That was a fantastic presentation. Now, I'm looking to the chat box, and we will come back to these questions later. Now, I have a question for you. Well, a very practical question coming from the chat box. Can you use PPG to determine the length of the segment which need to be stented? And it comes back to the lima. Yeah.
Yeah, that's a very good question. And well, here, I think we have to use all the tools that we have. We're talking today only about physiology, but we also have to acknowledge that there is a huge benefit of using intracoronary imaging, being IVUS or OCT. So what happens sometimes in these vessels with very focal disease is that the length of the pressure drop is very short. So if we can call it the length of functional disease, is going to be shorter to the anatomical lesion. So this is a question that I don't have an answer. I would say that we have to integrate physiology and imaging, and I would advocate for going at least for a strategy of normal to normal based on intravascular imaging, not forgetting that 70% of the target vessel revascularizations that occurs in trials are related to the stent. So we have to avoid to land in lipidic plaques, we have to achieve a big stent expansion, and we have to avoid complications further down the road related to the stent.
Now, I have a last question for you, Carlos. You have a patient with 66, a fractional flow reserve of 66 in the distal LAD. What is the link between the, let's say, the focality of a lesion? When you have two patients, same FFR, what is the reason why a focal lesion will be, let's say, accompanied by a better result and better outcome? What is the link between focality and outcome?
Well, so we have to understand that what we do, PCI, is a focal therapy. So stents are, the longest that we have is 3-4 centimeters, and these are actually focal therapies. So we are very good at treating focal disease. And this is the reason why the PPG help us identify those who benefit, and you have seen the data of angina. So I think it relates, Bernard, to the tools that we have in this time to treat the patient and the disease that the patient presents with. And then when you make the link, that is very easy to understand that diffuse disease is probably not for PCI, whereas focal disease is probably the best scenario for PCI.
Okay, any burning question from Jeroen and Divaka? Otherwise, I will go to the conclusion slides. So you can put the next slide. I will go to the next slide myself. Okay, we have focused on the epicardial disease, and I think you all understood that fractional flow reserve is an index of global epicardial resistance. And I have put on the slides an index. Actually, it's not the right word. FFR is also a quantitative characterization of global epicardial resistance. That's the classical FFR. When you put the wire in the distal LAD, you will have an index or number which tells you something about the whole resistance in the epicardial vessel. PPG adds a second dimension, I would say, to this stationary FFR, and PPG is a quantitative characterization of the distribution of this resistance. So that's for the definition. Now, I think that in terms of take-home messages, and at the risk of repeating what you guys have said already several times, we all agree that atherosclerosis is diffuse by nature. and more than we think when eyeballing the angiogram. We are not good at all in eyeballing an angiogram. That is something we know from since ages, but we are also not very good in eyeballing pullback pressure tracings, as Jeroen told us. PPG quantifies the diffuseness of atherosclerosis, and if you have to remember one thing is high PPG equal focal, low PPG equal diffuse disease. And the epicardial function can be completely quantified by the, let's say, the combination, which is automatic, I would say, of fractional flow reserve and PPG. Now, Carlos has shown us, and that's of course very important, that high PPG means high post-PCI FFR. But I would like to insist on the fact that the PPG is recorded before the PCI. So with pre-PCI physiology, we can already foresee what will happen afterwards. This means a large gain in fractional flow reserve, and this also means better outcome. And to summarize completely, I would say that in an era during which everyone is gargling about precision medicine and nobody knows exactly what it is, I think that this at least is what we can call second generation physiology, and has, as Carlos has said, the potential to refine our indications and even the appropriateness criteria for PCI in patients with stable coronary artery disease. Thank you very much for your attention. The next module, the last module, module 6 of this series of webinar, will be devoted to the microcirculation. This will be also second generation indices for the microcirculation. Thank you very much. Thank you for joining, and good evening to everyone. Bye-bye.